Okay, so that's 4 o'clock, so we're going to get started. Hi everyone, I'm Anna. Welcome to this webinar. So welcome to this webinar on incorporating model-based geostatistics into the Tropical Data Service. I'm Anna Hart. I work at the London School of Hygiene and Tropical Medicine, and I'm the project manager for Tropical Data Geostatistics. Sorry, 1 second. My mouse appears to have disappeared. Okay, here we go. So this is the structure of the webinar. First, I'll go through some webinar admin details, such as how to ask questions and choose the language of your choice. We'll then go straight into an overview of model-based geostatistics, which I'll refer to as MBG, presented by Lancaster University. Next, we'll review some use case examples of how MBG has been used in trachoma surveys already, and then on to how MBG will be incorporated into the Tropical Data Service. Finally, we'll look at the research that is currently being done and the next steps. We'll finish with a Q&A session with our panellists from the WHO, Lancaster University, Tropical Data, Task Force, and RTI. So first off, some webinar admin details. We have simultaneous interpreters available for French, Portuguese, and Spanish. If you click on the interpretation symbol shown in the image in the top right, you can choose the language of your choice. This webinar is also being recorded and will be available on the Tropical Data YouTube channel. You do not have access to your cameras and microphones, as there are quite a few people on this webinar. So if you have any questions, please ask them in the Q&A box. You can also vote on questions that interest you, and these will be prioritized in the Q&A session at the end. If you have a question for a specific panelist, please indicate this by stating the name of the panelist in the question. This webinar is set for 1 hour, so if there are a lot of questions, we may not get round to answering all of them, but we will respond to all questions posted in the Q&A in the post-webinar report, and this will be made available on the Tropical Data Resources page. The link to the recording will go out in the next Tropical Data newsletter, so please subscribe if you haven't already. So let's get started with the webinar. We will first hear from Misaki Sasanami from Lancaster University, who will give an overview on model-based geostatistics.
Hi, my name is Misaki Sasanami. I'm a research associate at the Lancaster University. From this slide, I'd like to give you an overview of geostatistics. To assess the elimination status of trachoma, Tropical Data supports the field surveys and analyzes these data to estimate the TF and DD prevalence for each evaluation unit or EU. However, as we progress towards the elimination, it becomes more difficult to estimate the low levels of prevalence. And it is impossible to estimate the prevalence in EUs where surveys cannot be conducted. Another issue is that the 95% confidence interval ignores spatial correlation, which is statistically less reliable. Also, the interpretation is difficult. For example, there is no consensus regarding how narrow it should be. To address these challenges, we are researching the use of model-based geostatistics, or MBG. We'd like to stress that the current standard methods will not be changed or replaced, but MBG is an enhancement of the current method. So what is MBG? Geostatistics is a branch of statistical methods relevant to the analysis of geolocated data, with the aim being to study geographical variation throughout a region of interest when the available data are limited to sampling locations. What differs from non-spatial statistical methods is the ability to quantify and account for spatial correlation, the phenomenon that things are more similar when the geographical locations are closer. It is known that trachoma prevalence tends to cluster spatially, so in such a case, we can leverage the spatial correlation so that information from sampled locations can help understand neighboring and sample locations. How does it work practically? As shown in the map on the left, we have the data only from samples because it is infeasible to examine everyone in the area of interest. If we simply calculate the prevalence, we implicitly assume that the prevalence or the risk of the disease is uniform over space within the same EU. In contrast, MBG allows us to treat the risk surface as continuous over space, as shown in the middle map. Risk factors for infectious diseases, such as temperature, precipitation, and population density, tend to be correlated and smoothly vary over space, and so does the disease that depends on them. This is one of the reasons why we often see the spatial correlation in infectious diseases. As the next step, we can aggregate the continuous surface at any desired spatial scale. For trachoma, it can be at the EU level. Furthermore, we can provide the predicted probability of elimination, which can be interpreted as the probability of having achieved the elimination target. As the value gets closer to 100% or 0%, we can be very confident that the elimination has been or has not been achieved. If the value is close to 50%, there is a lot of uncertainty and we are not very sure about the elimination status. As opposed to the conventional 95% confidence intervals, the predicted probability provides more tangible quantification of uncertainty. These two main outputs are statistically reliable and advantageous from mainly two aspects. The first benefit is the improved precision in the prevalence estimates. Because MBG can use the data from sample locations to inform neighboring and sampled locations, we can make the most possible use of limited data. Model fitting process allows the data to choose optimal strength of information we can borrow from nearby locations. The previous study analyzed the TT data from Ethiopia and shows that MBG has yielded 10 times more precise TT prevalence estimates than the current standard methodology. The second benefit is the usefulness of predicted probability of elimination. I'd like to use an example from Brazil here. Traditionally, based on the estimated prevalence, we classify the EUs into two categories: having achieved the elimination or having not achieved the elimination. In the left map, we would conclude the green areas have achieved the elimination target, whereas the yellow area has not. However, this does not tell you anything about uncertainty about such classification. So instead, if we look at the probability of elimination produced by MBG on the right map, in the area with the red color, the probability of elimination is around 70%. This can facilitate the discussion of if that is a tolerable uncertainty level for the policymakers. Because of its usefulness, MBG has been increasingly used for a wide range of infectious diseases. This is a list of NTDs that have used MBG to guide the elimination efforts. As a summary, I'd like to highlight the difference between the standard survey approach and MBG methods. The current approach calculates TEF and TC prevalence EU by EU as the surveys are completed. The age or Asian gender-specific prevalence of TEF and TC is calculated, and they are standardized using the census data. This produces the standardized TEF and TC prevalence in each EU. In contrast, using MBG, we are combining the data within the same country. We follow the same steps as the standard methods in that we calculate the age or Asian gender-specific prevalence and then standardize them. The main difference is that we also account for spatial correlation between sampled classes and individual level variations within the classes if the data supports their evidence. Furthermore, we started investigating if accounting for other factors improves the accuracy and precision. The final outputs are prevalence and the predicted probability of elimination.
So Now we have a background on what MBG is and how it works, we will go on to some examples of how model-based geostatistics has been used already. Our first speaker is Dr. George Kabona from the Tanzanian Health Ministry, and I will then present a case study that the Nigerian Health Ministry have kindly allowed me to include.
My name is Dr. George Kabona, the NTD Program Manager from Tanzania mainland. And today I would like to share with you the experience using the geospatial methods in program delivery. Tanzania has been actively employing the surface strategy since 1999, starting with a pilot initiative in some districts. Now, following comprehensive baseline surveys conducted nationwide in 2004 and 2012, targeting 100 districts identified as being most susceptible to trachoma, the mass drug administration efforts were expanded. This expansion actually covered a total of 69 districts, equal to 7 evaluation units. And in addition to that, 89 districts were deemed eligible for the TP surgery program. Historically, the prevalence of TF among individuals aged 1 to 9 years and the prevalence of TP in adults aged over 15 years have been assessed for currently. In cases where conducting TF surveys isn't warranted, it becomes appropriate now to carry out a TT-only survey with the objective of estimating the TT prevalence. Now, let us turn our attention to the 11 districts of interest for today. These 11 districts will conduct the TT surgery program interventions, and the ones at the end they were eligible for impact assessment. But according to the WHO guideline, because the TF was below 5%, then these districts were eligible for TT only survey. Now, although these districts are safely completed this surgery program, eliminating the TT backlog through full geographical coverage, which is now the option to show the elimination, observations from the frontline health workers raise suspicions about the TT prevalence, and probably full geographical coverage cannot be enough to explain the prevalence. Therefore, these suspicions were later followed by the program and confirmed, and therefore prompting a request for a TT-only survey to validate the prevalence. Now, recent evidence indicates that combining neighboring districts with similar characteristics into large evaluation units known as super evaluation units yields accurate TT prevalence estimates, especially when using the geostatistical design approach. As a program, we chose this approach not only due to its reliability, but also due to cost efficiencies achieved by reducing the number of disk clusters within the super evaluation unit. Consequently, we amalgamated the 11 district councils into 5 super evaluation units. This map is just meant to show how the 5 super EU were formed with an average of 3 districts each, and a population ranging from 340,000 to 507,000 people. We employed trachoma survey data from 2014, 2017, and 2018 to employ a geostatistical approach in the random selection of 30 villages for each super evaluation unit. Just as an example on how the cluster were distributed, look at the map, and those blue highlighted points showcasing the distribution of the clusters selected for Super EU. Now let us look at the results. We conducted data analysis by employing the binomial geostatistical model, which was applied to the datasets. This model allowed us to generate the likelihood that the standardized TT prevalence at the Super EU level would be below 0.2%. Look at that table. The outcome of this analysis indicates that the probability of all evaluation units having successfully achieved TT elimination was nearly negligible. As a result, a decision was made to reinstate the TT surgery program across all those 11 districts. Additionally, the plans are underway to carry out impact assessment using the same methodology and within the same super EUs once the TT surgery program is completed. Thank you very much for listening.
Next up is the case study from Nigeria, kindly provided by the Nigerian Health Ministry. So this was a study on a single EU called Newman LGA in Adamawa State, Nigeria. Baseline mapping in 2017 demonstrated a TF prevalence of less than 5% and a trichiasis prevalence just above threshold at 0.21%. And the neighbouring EUs all had trichiasis prevalence below 0.2%. The original objective here was to determine whether the difference in observed prevalence between surveys was biologically meaningful or an artefact of sampling error. So an MBG model was used to combine data from all surrounding EUs to try and generate a new estimate. The new estimate had a PPE of 0.447. So that's around, we have 50% confidence that the elimination threshold has been reached. And as you can imagine, this is too low to rely upon. So therefore, a new approach was used, and this was to see whether MBG can be used to refine the geographical area for trichiasis case finding activities. And we were interested in this because in many districts, the trichiasis prevalence is not homogeneous across clusters, but rather exhibits signs of focality, indicating that the programme challenge is confined to a specific geographic area. As Masaki mentioned in her slides previously, MBG allows model predictions to be aggregated at any spatial scale, so for example, subdistrict or village. It can identify geographical areas with a good probability that the prevalence of trachoma is high and could allow for better targeting of programme resources. It may also show where it is appropriate to split the district, stopping treatment in areas where there is a high probability that the threshold has been achieved, or reframing EUs altogether if this would be politically acceptable and allow for practical implementation of future interventions. So with this in mind, using MBG, a map of the predicted standardized TT prevalence over a grid over the whole EU was generated. The MBG model results predicted that the majority of TT cases would be located in the west of the LGA Newman EU, as shown in this graphic on the right here, where green predicts high TT prevalence. However, case findings showed that most TT cases were actually found in the east. As previously stated, the predictive probability of elimination, the PPE, of the entire EU was around 50%, indicating there was a lot of uncertainty in the model. This uncertainty was likely due to a lack of data. There was a high proportion of zeros in the dataset, meaning there were many clusters with no TT cases at all. Due to the uncertainty implied by the 50% PPE, next steps for this EU would be house-to-house case searches or implementing a treatment programme and resurveying after an interval. So those were some examples of how geostats models have been used so far, but there are other ways that geostats may be able to help. For example, as of March 2022, there are 17 countries covering 240 districts reported by the WHO as being hard to reach, meaning surveys cannot be conducted and countries are not able to know their trachoma status. MBG can be used to pull data from surrounding EUs to estimate the prevalence of TF and TT. MBG may also be used as a form of post-validation surveillance, where we can combine data from baseline, impact, and surveillance surveys to estimate trachoma prevalence and try and predict whether or not any recrudescence may occur. So in the next section, I'll give a brief overview of the background of when Tropical Data decided to start investigating the use of MBG, as well as how we are working on incorporating MBG, as there are a number of criteria that need to be met. So the idea to use MBGs in trachoma control has been in the works for some time. It was first formally discussed in 2018 at the 4th Global Scientific Meeting, with the outcome being that MBG analysis was deemed an acceptable way to demonstrate TT elimination had been achieved. It was also discussed at the Endgame Challenges meeting in December 2021 and at Get 2020 in Istanbul in April. So we know that MBG has WHO approval, but that doesn't mean that it will be used for all future trachoma surveys, and we'll look at the criteria needed to run MBG in the next slide. So this is a decision tree that provides a simple overview of what we need in order to run an MBG model. One of the first things is whether we have up-to-date shapefiles for the EUs in question. And this is something that I'll explain further in the next slide. The data also needs to show spatial correlation, the analysis of which will be supported by the Centre for Health, Informatics, Computing and Statistics at Lancaster University. Household or cluster level GPS, no evidence of large population movement, and access to the necessary covariate data are also all required in order to use MBG. If we don't have any of these things, then we can't progress with MBG, and we default to the standard data analysis methods. And as demonstrated in the previous Nigeria case study, even if we do have enough information to run the MBG, if the PPE is too low, we would default to standard data analysis methods as well. So I mentioned in the previous slide that I would explain why shapefiles are important. So firstly, a shapefile describes the location, size, shape, and boundaries of a defined area. Administrative changes can occur fairly often. So for example, a common one is when a district is split into two separate districts as shown in this graphic. Shapefile creation often lags far behind these changes, and if surveys are planned in newly formed districts for which a shapefile and/or a map does not yet exist, we are missing a crucial piece of the information needed to do a cluster selection using geostatistical methods. Standard survey methods can be used, however, as long as we know which district each cluster belongs to. So now we'll go on to review the current research that the Tropical Data team are involved with and the next steps for this project. So I mentioned in previous slides about covariates such as rainfall or altitude, and these are two variables that may affect trachoma prevalence. Recent research by Clara Berger found a number of ecological factors that are linked to high trachoma prevalence, including precipitation, temperature, altitude, ruralness, and access to medical services, schools, and water and sanitation. Aridity and distance to stable nightlights were indicated for TT prevalence. However, just knowing what the covariates are isn't the end of the research. We still need to decide which covariates should be included in the model and how beneficial they are. And linked to this, should the models be standardized or should they be customized by country? So Misaki and Clara are both looking at how variables influence trachoma in different countries, and it's possible that we may need to customize models for each country on a case-by-case basis. For example, in country A, it might be rainfall, altitude, and aridity that influence trachoma prevalence the most, whereas in country B, it's potentially access to water and sanitation. So you can see that we wouldn't be able to run identical models for both countries. Another part of the research is deciding where the variable data should be sourced, as consistency is really important. And also, what do we do if the covariates change over time? These are all questions that need to be answered before we implement MBG within the Tropical Data Service. So our next steps are to explore the level of MBG analysis automation. This relates to deciding which covariates to use and how customized models need to be. We will then need to develop the analysis code and incorporate it into Tropical Data's existing processes. We also need to develop a user-friendly interface that is integrated with the Tropical Data platform. We will be developing guidance materials on result interpretation for countries. And we'll also be writing a Tropical Data MBG methods paper, which will help document and be transparent about the process and methods. And finally, something really important to highlight, this process is a collaborative effort, and we're keen for as much input as possible from everyone in the trachoma community. This webinar is the first step in getting feedback, but we'll be looking for continuous involvement from all individuals and organisations interested in using geostatistical methods for trachoma elimination activities. So to summarise, the MBG model is an enhancement to improve survey precision. It can account for other covariates, such as rainfall, altitude, or temperature, for example, but multiple criteria need to be met to use MBG. And just to point out again, the final output is point prevalence and PPE. Standard field-based survey methods will remain unchanged, and as I've hopefully shown in this webinar, there's still a lot of work to be done before widespread implementation. So just to wrap up, I would like to highlight the important people involved in this project, some of which are available today to answer your questions in the Q&A session. So we've got Sol from WHO, Misaki and Emanuele from Lancaster, Emma and Clara and Anna from Tropical Data, and Jeremiah and Ngondi from Tropical Data, Stephanie Somerville from Sightsavers, and me. And just one final slide. So the reason this is a webinar is because at GET 2020 in Istanbul in April 2023, we presented some research on MBG. And to our surprise, there was quite a lot of confusion and a lot of worry about how MBG might change tropical data methods. Eric from USAID was there, and he was really supportive, and he suggested that we create a webinar to explain it in more detail. So this webinar is dedicated to Eric Mosher. So thank you to all the health ministries that have allowed their data to be used to test out the MBG methods, in particular to Nigeria and Tanzania for allowing me to show it today. And thank you to all the partners involved. So we'll now start the Q&A session where we will answer the questions you've submitted during the presentation. Our panelists today are Anna Bakhtiari, Sol, Clara Berget, Emanuele and Misaki, Stephanie Somerville, and Emma Hardingesh. Unfortunately, George Gabona from the Tanzanian Health Ministry and Nicholas Olabio from the Nigerian Health Ministry were not available to answer questions today. So we have 3 questions so far. We will go with the first question. Has tropical data or the WHO established an accepted level of uncertainty for estimates of the probability of having achieved the elimination targets? So that's an excellent question. I'm going to hand over to you, Sol, for that.
Thanks, Anna. Hi, everybody. And short answer is no. We tried to have a bit of a discussion about this at the Alliance for GET 2020 meeting in Istanbul, and it's a question that needs some thought, because really it's a decision that is as political as it is technical. It's really a question about how much uncertainty people are willing to tolerate when WHO and the kind of global community agrees that a country has eliminated trachoma as a public health problem. So not yet.
Okay, hopefully that answers your question to an extent, Martha. And Scott Nash has a question. When borrowing cluster information from surrounding EUs, how are you accounting for the age of the data that you are borrowing? In some areas, you can have districts with a mix of survey data, possibly from many years apart. Are you comfortable using TT data that is 5 years or more old? So I think this is quite a technical question. So can I pass over to you, Misaki and Emanuele?
Yeah. So the answer is that we never combine, for example, data that are from different intervention at different intervention stages. So we never tend to combine data from baseline and impact survey. And we always, I think, select the data from the last survey. But can you remind me exactly what criteria we used in our last study, for example?
The EU's, we selected the most recent available data. So some of them were impact surveys, some of them were from surveillance surveys, but not from baseline surveys.
And I can say, at least in the case that we had, data tend to be very sparse. So in the same area, I think very rarely we had data that were from more than one different kind of survey. So I think this is a very I mean, the question raises a very important concern, but I think so far we have been quite careful in understanding what type of data we had, especially what type of the in intervention, what kind of intervention history they had, and we avoided combining data that were especially from baseline and other intervention stages. So that's a good question, but we are careful in the selection of the data set we do, and Ms. Hagi has just explained it.
Okay, lovely, thank you. Scott has another question. In the Brazil example, those districts were many kilometers apart. Were you still able to borrow data from such a long distance away, or does this work better when districts are contiguous?
So I don't think there is a better or worse in this case. It depends on how large is let's say the strength of the spatial correlation in the data. Sometimes you have correlations that are very long range, so you are able to borrow more information from a wide area. Some other times you have residual spatial correlations that are act on a smaller scale, so having more continuous districts would be more advantageous. In the case of Brazil, I don't remember exactly what was the scale of the spatial correlation, but there were also data that were from a completely different part. So we decided that I think they were actually on the west coast of Brazil, and that was just too far apart to be able to borrow strength of information across that wide area. But for this area, we consulted also with the people who provided us with the data, and there was quite common I think agreement that it was fine to combine this data within a model. Now, to what extent we're able to borrow information, again, it all depends on the data. Sometimes even if we having more data that are combined in a single model can help us to reduce the uncertainty. But of course, we are also making more assumptions that the properties of the model also apply to those areas. So we are able to essentially to borrow more information, but we are also making a bit more assumptions when we put the data from a wide area in a single model. So I think there is a general answer to this question, and it's a case-by-case decision. Yeah.
Great, thank you. And there's a comment from Felix, which I don't speak French, but Anna has kindly translated it for me, which says, in the case of the DRC with its insecure districts, this approach has many advantages. So thank you for that, Felix. That is really useful. Thanks. We have another question or comment from Martha. It would be ideal to consider involving stakeholders within countries to help building capacities to use MVG, Photochroma, and other NTDs. It is a complex topic for a program manager, so engaging others to help them with these methods would be ideal. Having the support of Lancaster University is excellent, but creating capacities in countries is needed. Sol or Emma, perhaps, for this comment?
I would actually turn it over to Lancaster. They've been extremely good about volunteering to undertake that kind of capacity building. So I'll let Emanuele perhaps respond.
Thank you. So I think that there are two approaches, I think, here to support program, the countries. So one is to do capacity building and training people, the local champions, the local, biostatisticians who have already some background knowledge to be able to understand this methodology. But that takes a long time because, in our experience, to train someone who has already a background takes years. It's not a matter of, just visiting Lancaster for 2 weeks and then you know everything. It takes a long time to train people. The other solution, the other solution is instead trying to develop something that can be easily used by program managers or other people in the health ministry so that can use this methodology without necessarily trying to understand all details. It's like driving a car. You don't need to know all details about how the engine works. And so we are trying to we are developing now a web-based application where we are trying to make the use of this methodology more easier and more accessible, especially to people who are not necessarily trained in statistics. This is still work in progress, but I think we have a prototype that we aim to, we will present to the WHO. I think it's going to be, I think, November or later. And then there is also plan to incorporate this app into tropical data as part of one of our control projects. So again, two solutions is training people, local champions, and another is developing tools that makes this model more accessible. And I think both solutions are needed. We cannot just do with one or the other.
Thanks. That sounds great. So on to the currently last question. So thank you for this webinar. I noted one of the possible uses for MBG was for inaccessible areas, but that in the criteria list, if there is evidence of large population movement, MBG cannot be used. However, I suspect that there is a big overlap between inaccessible areas and large population movement. Are there any plans to try and account for population movement and be able to provide a PPE? Emanuele Yamasaki, I think that's you again.
No, we already did these questions, I think, in the first webinar on people movement. So I think this seems to be an important topic, to which, honestly, I have not paid too much attention so far. But I think one of the main challenges is that trying to incorporate more assumptions to the model and trying to account for more, nuances of the process, I think will require also the use of more sophisticated models. Now, one of the issues that we have already, let's say, reaching almost a breaking point by using even the standard model that makes minimal assumptions. So it will be a challenge because one of the key features of our modeling approach is that it's a data-driven approach, meaning that the performance of the model and its accuracy is strongly tied to the data. So if the data do not have enough information, we cannot just force the model to tell us what we want it to tell us. So it's a balance between trying to fit a model that tries to account for as many nuances as possible, but also acknowledge that there is a lot of uncertainty from this data, and we cannot just force the model to try to make up results so that we reinforce what we expect. Essentially, it's a balance. And I think trying to incorporate people movement is something we need to think more carefully, and how we can probably incorporate this into the existing geostatistical framework in a way that is, say, empirically possible, meaning that we can estimate using the data. So it requires more thought for us, I think.
Great, thank you. So we have another question from Nigel Bolster. So sorry for the basic question. All questions are good. Do more clusters typically need to be visited in MBG compared to a standard survey?
So, well, generally, what we have shown is that MBG requires fewer clusters compared to standard survey if the survey is done using a geostatistical approach, because geostatistics, so far, I think for trachoma has been used mainly to essentially assess the elimination of an evaluation unit. But the other application, which we actually the other use is to design a survey. And we have done this extensively, especially for soil-transmitted helminths and lymphatic filariasis, where we have shown that if you use an MBG approach to design a survey, you can save quite a lot in terms of how many samples you need, because MBG models can also tell you where to sample in order to increase the chance of classifying an evaluation unit correctly. So in a sense, MBG is always a better alternative to random sampling. Now, I don't know exactly how the standard survey works, but we have already shown this for lymphatic filariasis and soil-transmitted helminths, that MBG brings huge advantage in terms of cost saving when doing a survey. Yeah.
Excellent, thank you. So definitely a good question. So we have a question from, I'm afraid I can't tell your name, D. Stukel. As new TIS and TSS surveys are implemented over time, I gather the MBG approach can integrate new information from these surveys and update the predictive models. Is there a way to keep the older surveys and downweight the importance of older TIS, TSS data that is integrated into models? Emmanuel?
I was trying to remind myself what this and TSS was, but now Misaki explained. So, I mean, so in a sense, what I think this question is hinting to is that we should develop a spatiotemporal model for trachoma, because a spatiotemporal model would allow for a natural weighting of of data that are collected over time. But I think one of the big challenges we have is that the data set for trachoma are not collected most of the times to understand temporal dynamics. And so it's difficult for us to because sometimes you have data that are from different time periods, but from different regions. So there are spatial variation that is confounded by temporal variation. And this makes the fitting of a spatiotemporal model quite difficult, which is why we have to develop some criteria to understand how we can combine data sets that are from different time periods, but that in a way reflect the same situation on the ground. So for now, all the survey data in the model are in a sense weighted the same way. There is no distinction between data from different surveys. But I agree that it would be a better approach to have a spatiotemporal model where essentially time is more explicitly acknowledged than in the approach we currently use. But again, because we are really struggling to fit these models that are simpler than a spatiotemporal model, fitting a spatiotemporal model would require to buy even more information from the data, which will induce inevitably more uncertainty also in our predictions. So I think to keep in mind in statistics is that the more you want the more you want to buy from the data in terms of information, the more uncertainty you will have, because there is no free lunch. Yeah.
Yeah, a good point. So we don't have any more questions at the moment. But I did say this on the other webinar session yesterday. I'm happy to receive questions directly. I think everyone has my email address. And as I said, we're really keen to collaborate with everyone involved. So please do send us emails if you have any questions, and I can palm it off onto the right panelists as needed. But if we don't have any more questions or comments, we can wrap this webinar up. Yep. Thank you so much to all the panelists for coming, and thank you to all the attendees for listening. In particular, thanks to Emanuele and Misaki for answering all the questions. And yeah, thank you everyone. Have a good day.